you. Thank you for the nice words. Thanks to chairperson. So, respected senior doctors and colleagues, at the outset, my sincere thanks to Bansi and Sir and entire Diabetes India team for giving an opportunity. So, my topic is on the practical tips for recognizing and addressing the insulin inertia with respect to primary care. So, we all know type 2 diabetes is the biggest epidemic of 21st century, and by 2045 nearly 125 million people are going to things with an impact of 70% increase with the things. So with this huge impact, what's the average HbA1c care? So as per the Diabcare India 2011 study, the mean HbA1c has been 8.9 plus or minus 2.1. So with this background, where are we after celebrating the centenary celebration of insulin, armamentarium of huge number of drugs? In spite of the things, only 1 in 4 patients with type 2 diabetes achieve the recommended targets. So despite 40 new treatment options approved since 2005 by FDA. So in 2025, still the HbA1c are at the level of 8.35 plus on things in spite of all the drugs. So with this, what is clinical inertia? So the failure to initiate or intensify the therapy when indicated or failure to act despite recognition the problem has become. So this has been a worldwide phenomenon. So delay of almost 3 years to intensify. So the very reluctance to advance the therapy may actually deter the patients from accepting the therapy. So this is clinical inertia. So what is the cost of inertia? Whether it matters? Yes. For every 20 persons with diabetes whose HbA1c is 1% above the target, they will suffer a microvascular complication. When the LDL level is nothing, they have a myocardial infarction, and the blood pressure is above, they have the same amount of microvascular disease. So clinical inertia, failure to advance the therapy when required. When you just see the percentage of subjects advancing when the HbA1c above 8, so these are the various things with respect to diet, sulfonylurea, metformin combinations. So patients remaining on multiple OADs for too long, insulin inertia. So we know the consequence of delayed intervention in persons without previous cardiovascular disease. Why should we address this insulin inertia? So 3 years after diagnosis, 50% of the patients required greater than 1 OADs as monotherapy, they doesn't reach the target. And by end of 10 years or 9 years, nearly 75% of the people need multiple therapies. So this is the scenario. Either we need to combine, or despite combination therapy, majority of the patients may need insulin by 9 years to maintain the HbA1c. So let me move on to the common barriers of the insulin therapy with respect to patients. Concerns about weight gain, hypoglycemia, fear of injection, lack of caregiver, diabetes distress, and perceived things. So these are the common barriers with respect to the patients. What are the barriers with respect to the physician and healthcare system? Lack of knowledge and confidence, issues with healthcare organization, lack of diabetes educators, inadequate infrastructure, concerns about weight gain, concerns about patient's fear and fatigue. So these are the whole set of factors which are the common barriers. So the clinical inertia is common, and the time course to action is nearly 8.2 years from the start of things. So progressing from oral therapy, lifestyle management, combination basal. So this has been a stepwise approach. There are many misconceptions about injectional therapy which are based on experience with insulin. The Dawn Summit 2004 explains about the misconceptions and the healthcare attitudes to the things. So always the physicians use insulin as a threat because believes the patients they doesn't want it and injections are painful. So these are some of the misconceptions with respect to the physicians. So what are the techniques how to identify and overcome the barriers? So to manage the fears and barrier related to injection therapy, 50% of managed to how to overcome the things. So identify and address the patient's obstacles, introduce insulin as a brief experiment, educate the patients on hypo, and consider the use of pens. So these are the little bit of examples how to overcome the fear with respect to the injections. So the patient's barriers once again to insulin use. What is the perception against the reality? If you just see 59 or 58% of the patients believe using insulin means they have failed the OAD therapy. So we know that OAD failure is due to progressive nature of the type 2 diabetes and the needle phobia. Once again, the current needles considered painless, easy to use, and the fear of complications. And to complications are not due to just uncontrolled progressive disease. Insulin actually results in reduction of vascular damage. So this is the reality with respect to the perception which has been the things. So the practical approaches. So always take simple steps to educate and engage the patients. Consider the available steps and make them educate with respect to the injection techniques. So what conversation was effective in providing the patients with confidence to start the injection? So it has been a UK patient response, gap response from the patients who have started on taking insulin and they found considering or controlling diet or working out what to eat has been the most important thing, and the fear of injection is less than 4%. So once again, this thing has been well educated. So these are the various trials or the articles where they have said about the insulin inertia. So what about the trends in India? If you just see, there has been an urgent need of reducing the clinical inertia against insulin initiation. So this has been with respect to the Indian scenario. So the key challenges from insulin users: social stigma, hypoglycemia, weight gain, adherence, cost, and education. So four cardinal principles for coping therapy with insulin distress: strengthening of self-care skills, optimization of coping skills, minimizing the change related discomfort, utilization of external support. So physiological barriers to insulin use. Five main concerns about the insulin with type 2 diabetes. Concerns about the medications, the anxieties about the injections, lack of confidence, impact of self-perception, and finally, fears about the diabetes progression. So we all know insulin distress. It is an emotional response of the patient to the suggested use of insulin, which acts as a major barrier to insulin therapy. So it is characterized by severe apprehension, discomfort, dejection, or denial due to perceived inability to cope. So reasons we all know: permanence of therapy, restricted lifestyle, life-threatening hyperglycemia, weight gain, and noodle phobia. So what are the irrational beliefs? There are many irrational beliefs. So I will not, one thing is I will never be able to tolerate the pain of insulin injection. So this has been the goal things which has been there for things. What are the strategies? Teach the patients about diabetes, introduce the concept of insulin therapy from the onset, educate the patients about diabetes progression before they actually need insulin. So distinguish between the natural progression and the complications of high glucose, not to threaten the patients with insulin as a punishment. So explain insulin action, advise to minimize the weight gain by decreased caloric intake and increased exercise. Explain the action of newer, more flexible types of insulin. Expose the patients to injection techniques
2 minutes,
under
sir.
medical supervision. Encourage the patients to try insulin for a shorter period of time while monitoring the factors. So the strategies to decrease the psychological insulin resistance or insulin therapy schedule adapted to the patient schedule, systematic desensitization and relaxation, share the success stories of other patients' experience. So these are the barriers and counseling strategies. So the key takeaways: early recognition is crucial. Overcoming the barriers requires a multifaceted approach. Patient-centered communication is the key. Initiation and titration should be simple and stepwise, and regular follow-up ensures better adherence and outcomes. Leveraging technology can improve insulin management. So all people with diabetes should be provided with quality professional education on medical nutrition therapy and at regular intervals. It is important that the healthcare professionals advise the patients about the proper way. While insulin distress is a part of diabetic distress, it is distinct and unique and warrants specific consideration. Psychological insulin resistance is a psychological barrier to insulin use on several levels, such as emotional, cognitive, behavioral, social, and relational, that needs to be addressed. Thank you all for patiently.